All right. Well, thank you, Dr. Weiss. And now we'll have Dr. Weiss and Dr. Scherer join us for the Q&A. Welcome. You guys are in the same room, it looks like. Okay, I like that. Yeah.
We are. This is from Jack, the little present that we are happy to keep at home.
That RheumNow wallpaper, it's now on sale. So congratulations on all of that. So we have a number of questions. Let's start out with Jose. A few people in the audience want to know about what you can do diet-wise to rectify and improve one's microbiome to treat disease specifically. Would gluten be helpful in treating PSA, and would it be so because of the microbiome?
Thanks for that question, Jack, and whoever asked that in the audience. I start from the latter point, and that is the very small studies on gluten-free did not pan out in psoriatic disease. In terms of modifying the gut microbiome, there are plenty of studies ongoing. One from Alexis and Lihi Eder. You probably heard her speak about some of that. We don't necessarily know much about what a beneficial microbiome would look like other than data that's emerging from Georg Schett and others that are doing high fiber diet type approaches. I think I mentioned that in my talk.
Another similar question is, are there any studies regarding sauerkraut, kimchi, and lactofermented foods in modifying the microbiome?
I don't know about the first two. The last one, lactose fermented. So the first idea behind the rationally designed sulfasalazine came from an esteemed Swedish rheumatologist, and the whole hypothesis was that rheumatology's ideology was a microbe in fermented milk, and that's how she pursued the advent and rationally design of sulfasalazine. But there's no clinical data that support any of those.
Not to go too far, but there was another question also on differences in SPA prevalence in developed countries and developing countries, with the developed countries presumably having less diverse gut microbiome. And hearkening back to the work decades ago of Dennis Burkitt, who observed that prevalence of many diseases in sub-Saharan Africa was much lower, and he attributed that to the fiber intake in those populations. So what about that? I know we think of SPA prevalence in terms of genetics and B27 prevalence, but what about gut diversity?
Yeah, all of those points very well taken. There's a study, it's a pivotal trial, PNAS, a number of years ago, looking at kids in Burkina Faso, for example. And they found that not only the levels or incidence and prevalence of some of these chronic diseases were lower, but in fact, the gut microbiota was less diverse, but much higher in terms of butyrate and other producers. So that's that. I will, one of the caveats with those hypotheses is that the way that certain developing nations capture data, epidemiological and otherwise, it's less robust. And so whether it is true that there are less autoimmune conditions, or it's just that we're not capturing them. Same with China, by the way, and Southeast Asia, at least in the 80s and 90s, where and Phil, you correct me if I'm wrong, but initially the idea was that in those populations, spondylo and PSA in particular were non-existent, and then we have now better tools to capture the prevalence of those conditions. So
one other comment to make is some of this is going to be balanced out by the fact that we end up seeing more in the way of what we call reactive spondyloarthritis, often in the developing world, just due to different microbial exposures. So interesting to think about gut microbiome being favorable on the one hand, but exposure to different microbes on the other, leading to more reactive spondyloarthritis.
Is there a role for microbiome in juvenile spondyloarthritis? Pam or Jose?
Sure. There's actually a lot of research going on the microbiome in juvenile SPA. Matt Stoll from University of Alabama is spearheading much of that. Much of his work to date has looked at differences in the microbiome between healthy children and spondyloarthritis, and there's many similarities, as you may you might suppose, in terms of findings in the pediatric population and the adult, but there's also some differences that may point to, again, some differences in pathophysiology and why the disease starts earlier in kids than in adults. It's also interesting, I'll add on that the prevalence of juvenile SPA across the world differs quite variably, and one of the highest prevalent areas is actually India and some of the Far East. So there may be some to the questions that were asked in terms of microbiome and diet differences.
Yeah. Philip, someone asked about the status of FDA approvals for SPA. Can you review that for us?
So we are anticipating that so what's pending? So the pending approval is, we think any day now, will be for upadacitinib in ankylosing spondylitis. And we've seen, as you know, tofacitinib being approved there. There are also a number of different JAKs that are in the pipeline for PSA, but they're a bit, the only two that we have so far are tofacitinib and upadacitinib. I think my thought is that your answer to one of the questions was, I think the accumulating data in both PSA and axSpA is very favorable for the JAKs. And one thing to keep in mind from a safety perspective is that these populations are a bit younger than the rheumatoid population that was studied in oral surveillance. And so there may not be as much of a concern in that regard as raised by the oral surveillance trial. We're also anticipating any moment a approval for the IL-17A and F inhibitor bimekizumab in psoriasis, and then we've seen some very positive data in PSA, and although I can't speak to it, there is data in now phase 3 and axial SPA for bimekizumab. So that this IL-17A and F inhibitor is coming along. We've got several others that are IL-7 in the IL-17 class that are less easy to pronounce, including sonelokimab, which is a IL-17A and F inhibitor that's a nano body type medication, and then one called Ixabop, that is, which is an IL-17A inhibitor. That's another very interesting molecular construct. It binds both to IL-17A and albumin. So the idea is increased tissue penetrance. So I think there's some, and then on the JAK side, there is deucravacitinib, which is going to be first approved in psoriasis and then hopefully subsequently in PSA, and brepocitinib. Boy, what a litany of pronunciations these are. And forgive me if I have not mentioned any others that are soon to be approved. But the other pathway that I think is one that is very intriguing to many people is the MK2 inhibition pathway, which is an oral medication.
Phil, can talk about bimekizumab, the dual AF inhibitor, and other dual inhibitors. The data looks good. I'm expecting them to get approved, as you said, but is there a potential Achilles heel with those, in that when I looked at the reports, it looked like they had more candida infections than you would have with just the 17A inhibitors. You know, prior to those drugs hitting the market, there was the possibility there would be more candidate. Really never panned out in the clinical trial results, but what dual inhibitors looked like it was much more.
So that is absolutely true in psoriasis, where we see candida rates in the single digits with the IL-17A inhibitors and in the mid-teens with the IL-17A and F inhibitor. However, as you get more into the PSA and AxSpA data, those frequencies are less. And so I think that what we're going to be seeing is that, at least in the rheumatic conditions, this is going to be something we talk about with patients, but I think it's overall less of an issue. Most of this is surface candida. It's not deep fungal infections. So I think that by and large, it's going to be manageable.
I think that's Achilles' toes, not Achilles' heel, that has the fungus on just.
So, Artie, before you ask your next question, I've got to ask Pam a question. Surely that MRI scan that was labeled D was from a different patient than the one that was labeled C. The absolute normality of that one MRI scan, and then the X-ray that didn't have overlying bowel gas or anything to confuse it. I'm partly joking, I'm pulling your leg a little bit, but that was just such, many of us in the audience were scratching our heads about that one.
I don't know if I remember exactly which slide you're talking about, but I will tell you that it doesn't surprise me at all in terms of feeling like X-rays and MRIs come from different patients all the time. I mean, we really have been fooled, I think, a lot in the past when we've tried to use X-rays to be even minimally helpful in the kids, both in terms of falsely reassuring us that everything looks fine, as well as really panicking the families that something looks very, very off, and then having the MRI done and everything looks totally normal.
Following up on that, someone wrote in, Dr. Rice, and said, do you read your own MRIs, or do you have a special ped radiologist who you trust to read them with you?
Yes to both, actually. Because a lot of my research has revolved around MRI, I've actually undergone all of the Spark training under the tutelage of Walter Maksimowicz, right alongside the pediatric radiologist that I work with all the time, and have actually participated as a rater alongside the radiologist in some of my studies, and I've done pretty well, which is good. I wouldn't say that I can actually read my own MRIs for other joints in the body, but I'm really pretty good at the pelvic MRI. But that being said, I am pretty unusual, and many of you may be surprised that pediatric rheumatologists actually do not standardly read their own imaging. Across the board, we rely very heavily on the radiologists at our institutions, which is unfortunate. I think, the adult rheumatologists that I've interacted with quite frequently always look at their own images, and I think that's something that the peds community really needs to strive for. But I also do have my favorite, very trusted radiologist at CHOP that I will go to and say, I often try and say, this is what I think, what do you think? And unfortunately, we still, even at a premier institution like CHOP, we get reads that sometimes I disagree with. Then again, I think I need somebody more experienced to back me up before I contradict it.
Jose, John Goldman in Atlanta asked the question, do germ-free animals in germ-free environments have a microbiome? And another question sort of related to that is, you alluded at the top of your talk about the loss of diversity becomes associated with more severe disease. Is the loss of is it diversity that keeps you healthy, or is it the loss of diversity because you have the growing dominance of one or two species that are become more pathogenic?
Yeah, more of the latter. It turns out that inflammation equals dysbiosis, meaning loss of diversity. In general, that's true in cancer, immune-mediated inflammatory diseases, metabolic disorders. So, the question is always how much of it is, directionality, right? What's the chicken or the egg? We think, and the spondy groups that have looked at this are a little perplexed. The Belgian group have looked at a very specific microbe, dialister, but I don't know that they pursued that, but it's essentially very well correlated with BASDI and ASDA scores as well. So this will be the second study showing that correlation. Number two, yes, so germ-free animals don't get disease in general. There's one peculiar model in which the pathophysiology is essentially the reverse, meaning that they only get disease in the germ-free environment. But most animals, and I can name it, HLA-B27 transgenic rats, SKG, CIA, whichever you pick, they need microbes to develop their phenotype. And if I may add one issue related to what's coming, and I'm plugging in some very unique, innovative dual approaches to immune-mediated diseases. And there's 17A and F, for sure. There was a program on anti-IL-17 and TNF bispecifics that Phil actually led with AbbVie, if I remember correctly. But now there's the Vega study. I don't know if you have paid attention to that. Yeah. Now, Vega is, it's inducing remission in ulcerative colitis in particular, with a 23 and a TNF blocker against either monotherapy alone. Related to that, there's Affinity, which is already launched in psoriatic arthritis with a similar design, but slightly different. I'm sure some of you are participating, but it's a very intriguing new era of trying to modulate disease through a dual inhibition approach. So that's fascinating and exciting, at least for many of us.
If I could add a comment about what Jose just was speaking to, and if I'm allowed to make any off-label comments here, hopefully I can, or? Sure. Okay. Many of us are in the position where we've had patients who have been around the block many times. And so the whole issue of either bispecifics or combination medicines is pertinent. And we are now trying them in the clinic, even though we don't have clinical trials yet, except for this fascinating trial that Jose referred to, which is combining a TNF inhibitor, golimumab, along with a IL-23 inhibitor, guselkumab. So the key, I think, with that type of combination is putting together a drug that has very low signal for infection, for serious infection, with one that is kind of more standard in terms of risk for serious infection. So we have of course, used Primilast plus any of the other biologics. We've used IL-23s along with any of the other biologics, partly because the former has very little in the way of safety or infection signal. I do have more caution, though, in using two drugs that have meaningful serious infection signals, and because I've run into trouble in a few instances there. So I think it's an important area to be going into doing combination therapies more like the oncologists do to get their patients into remission, but with caution along the way about serious infection.
Yep, question?
Yeah, about kids and metabolic disorders. We see very often with our adult psoriatic disease, but what about your kids? Do you see that the kids you have will present already such a subgroup with more metabolic issues, or they grew up to develop that? Can you tell?
So can you clarify what metabolic issues you're talking about?
Is it lipidemia issues?
Diabetes and dyslipidemia?
Yeah, I think we see adults.
Not to an unexpected amount. Dyslipidemia in kids is pretty rare, although I guess we do see some elevated lipids and triglycerides when we're doing initial baseline screening before we start some of the JAK-STAT inhibitors. But some of these kids will have family history of dyslipidemia, but not really to an extent that would raise eyebrows. And we don't routinely screen lipids on most of the other medications. So I guess it's possible, and we just don't know the answer to that yet, but there's not really an indication, especially in the under 18 to do it usually more than once, and that's done by the general pediatrician. In regards to diabetes, certainly we do see a handful of kids who have type 1 diabetes or who have a family history of type 1 diabetes, but not any more often than we would see something like thyroid disease in family history or thyroid disease in the patient themselves. We do see a lot of celiac disease in the kids. We see a lot of concomitant IBD.
Okay, Philip, you set yourself up for this one. You showed a lovely spine X-ray, and there were marginal syndesmophytes, but then there was one that was sticking out a little bit. So someone asks about DISH versus AxSpa. Can you always tell? Are they different? Are they similar?
Yeah, I did set myself up for that one, didn't I?
Oh, you're thinking about that. My answer is Dish is always in a cranky old man. Not that I'm a cranky old man, but...
So here's where I end up depending a lot on this radiologist that I was referring to earlier, who I got on speed dial. I can text him, I can cell phone him, and he has no hesitation to go look at a colleague, the read of a colleague, and either put in a different report if his colleague was wrong, or at least teach me about it. But we struggle with some of these DISH cases because these patients have significant functional disability, they have pain, oftentimes. We're frustrated by being limited to non-steroidal use only or other non-narcotic analgesics. But I think it's clear, it's sort of like the difference between erosive OA and inflammatory RA or PSA, where we feel comfortable, obviously, about using immunomodulatory drugs for the clearly immunologic diseases, and we're drawn toward trying something in these erosive OA or DISH type patients to trying something just to see if there's any response. But I think it's an important distinction that we need the radiologist to help us with.
A question for both Pam and for Philip from Dr. Eugene Fung in the audience is, how do you treat spondylodiscitis? And why don't you also answer for me, where do you see spondylodiscitis? So, I think the test question is, it comes up in SAPHO all the time, but SAPHO is rare. How often do you see spondylodiscitis in spondyloarthritis? I don't think I see it very often.
So, Gene, you're right next to the microphone. Do you want to can you describe the case to us that you're thinking of?
Actually, we have this patient back pain, presumptively after trauma. However, it's showing bone marrow edema and definitely showing the change in the disc. And radiologists agree with me this is a discitis. He will say it's infectious. This patient been followed for weeks without infection. So it's an AS patient.
I'm sorry, but how was it confirmed other than time that the patient did not have an infection?
Well, certainly we have no evidence of any, but it's the leukocytosis, elevated xray or CRP. But the patient is pain in the local area.
Got it. Pam?
We don't see much spinal involvement in kids at all.
Yeah.
So this is
So back to you, Phil.
this is a tough one
I mean,
because I would be a little concerned about a low-grade infection, something weird like brucellosis or something that is weird in that regard. I've also seen cases, like for example, there was a prominent case that we had locally of somebody who had calcium pyrophosphate disease that presented in this manner that you're describing. So I think about weird things, and none of them of which are going to respond to say, an immunomodulatory drug, and just being really careful about making sure that you've ruled out infection in every way possible. What did you end up doing with this patient?
Well, using NSAID and along with the interleukin-17, and the patient seemed to be stabilized, but I think still have symptom for the patient. So I think it's a good idea for us to follow on infection or follow on the MRI. But along that line, actually, I have a question for Dr. Sir, because we don't talk to Dr. Sir very often. This morning, Dr. Choi said NSAID can change the flora of the microbiota. So when we are treating SPA, we're using NSAID first line, right? And so if you put the patient on biologic, would you maintain the same NSAID or you would stop it? Would that again change your flora? Would that affect your disease one way or another?
Complex, but first thing I'm going to say is that you sounded like my mother-in-law when you said you don't talk to me as often. For good reason. Number two, yeah, the data on NSAIDs as modulators of microbiota, it's not that robust. There have been some data showing particularly diclofenac and some others, but mainly they relate to how the microbiota alter the diclofenac and some other NSAIDs to make them somehow more toxic to the gastric lining. But in terms of community composition modification, I don't think that the data is that robust, at least not in the clinic. So I'd say I don't necessarily see that connection of switching NSAIDs when you try and modify the therapeutic approach with the biologic and connect with the microbiome. I don't have that good of an answer on that one.
Well, just one historical question. Of course, Dr. Odell and Dr. Alagon use minocycline in treating rheumatoid. So the effect of those drugs, or at least nobody using now, would that still have some value because they are changing the microbiota?
Thanks for the question. The data at the time, and I think still is the case, is that minocycline at those doses were mostly affecting anti-inflammatory downstream effects through MMP production or blocking MMP production. I don't think it had to do with its antibiotic properties. I see my good friend Audie nodding, so I'll pass the mic to you.
Thank you.
All right, Pam, Jose, thank you very much for joining us. This was a great discussion, great session. Thank you so much.